Hi, my name is Alyssa Schloop. I'm a fourth-year OBGYN resident here at Beaumont, and my project is entitled Uterine Carcinosarcoma, a retrospective analysis of adjuvant radiotherapy treatment. Uterine carcinosarcoma, or mixed Müllerian tumor, presents a rare and aggressive subtype of uterine cancer, accounting for less than 5% of all uterine malignancies. Compared to other types of uterine cancer, CS is more likely to present with metastatic disease and is overall associated with worse survival outcomes. Adjuvant radiotherapy has been shown to decrease risk of local recurrence in these patients. Therefore, we performed a retrospective analysis of patients with uterine carcinosarcoma treated at our institution to examine outcomes and toxicity profiles for these patients. So carcinosarcoma shares risk factors with other endometrial cancers, including nulliparity, obesity, exogenous estrogen exposure, and tamoxifen use. About 10% of these patients present with metastatic disease, and 60% of patients have extrauterine disease on imaging at the time of diagnosis. NCCN guidelines lay the groundwork for adjuvant therapy for these patients, much of which is dependent on stage. This is a flow sheet of the NCCN guidelines for adjuvant treatment specific to stage after surgery is completed. It also has parameters for suggestion of adjuvant treatment for patients that aren't suitable for primary surgery. As you can see, from stage 1A through stage 4, these patients often undergo multimodality approach to their adjuvant treatment, including systemic therapy with chemotherapy, vaginal brachytherapy, and often pelvic radiation as well. So our study was a retrospective descriptive analysis. We identified 24 patients with stage 1 through 3 carcinosarcoma treated in a curative fashion in our institution from 2002 to 2009. All patients underwent surgical staging with either an open approach or minimally invasive surgery with robotic assistance. Patients and tumor characteristics, treatment details, clinical outcomes, as well as toxicity data was collected for all patients. Clinical outcomes analyzed included local recurrence, regional recurrence, distant metastases, disease-free survival, and overall survival. GU, GI, and GYN toxicities were graded according to the protocol I'll describe shortly. Time to event analysis was performed using Kaplan-Meier method. The NCI common terminology criteria for adverse events is a descriptive terminology that can be used for adverse event reporting. These adverse events are graded, grade 1 through 5, with unique clinical descriptions, severity for each adverse event. For example, grade 1 is a mild asymptomatic or type toxicity or adverse event, where it may be a clinical or diagnostic observations only and no intervention indicated. Grade 5 would be a death related to this adverse event. Our results are described here. Our median follow-up time for our patient cohort was 2.7 years, and median age of diagnosis was 60. 32% of our patients had fibro stage 1 disease, 20% stage 2, and 46% stage 3. Following surgery, 83% of our patients underwent adjuvant chemotherapy. There was a variety of regimens used throughout this time span, but about 75% of our patients received carboplatin and paclitaxel. RT included pelvic RT alone in 6 of our patients, intracavitary brachytherapy alone in 9 of our patients, and combined pelvic RT with brachytherapy in 9 of our patients. 2-year overall survival was 82%, and 5-year overall survival was 69%, with a median survival time of 8.4 years from the start of adjuvant radiotherapy. Overall radiotherapy was well tolerated with low toxicity rates. Most commonly reported toxicities were grade 1 through 2, most commonly fatigue, diarrhea, rectal pain, dysuria, and vaginal discharge. There was no grade 3 to 5 toxicities. Here's a chart representing our clinical outcomes in 2 years and at 5 years. As you can see, the overall survival was less at our 5-year rate, but these rates are comparable to published data. So in discussion, adjuvant radiotherapy for carcinosarcoma as a part of a multimodality therapy is associated with excellent clinical outcomes. And these findings, as I mentioned, are comparable to published data in regards to overall survival and progression-free recurrence. The choice of adjuvant therapy is leaned preferentially towards chemotherapy, likely due to the GOG 150 clinical trial that showed a 29% reduction in the mortality rate over adjuvant radiotherapy. And the propensity for this disease to have extrauterine spread of the tumor makes early systemic treatment in the adjuvant setting more appealing. However, there is also known data regarding carcinosarcoma that suggests that adjuvant pelvic radiotherapy decreases the rate of local recurrence when compared to surgery alone. And as you can see, the toxicity profiles were low grade and well tolerated. Distant failure remained the most common treatment failure, an indication that there is need for improved systemic therapy in these high-risk patients.